Hi, everyone. I'm just going to take a moment to share my slides. Great. So as Janice said, I'm Anna. I am a fourth-year medical student who just applied into pediatrics, and I'm one of this year's pre-doctoral ethics fellows. So today, the title of my talk is When to Say No, Reproductive Justice, Disability Ethics, and Obstetric Violence. So the learning objectives for my talk, I am going to connect some key historical events that have shaped the reproductive justice movement to those that have shaped disability ethics and the eradication of eugenics. We'll discuss how contemporary discourse on reproductive justice for women with disabilities leaves conditions and rationale for withholding interventions underexplored. And then we'll illustrate how the principles of reproductive justice and bodily integrity can be applied in a specific case study that we actually saw in our service right as I joined the fellowship. I have no disclosures, but I do want to give a content warning. Much of what we discuss today is heavy and can bring up uncomfortable and hard feelings for people. If at any point you need to step away from the computer or sign off, that is absolutely okay. Please do what you need to do for self-care. So the case. So we saw N, who is a 30-year-old woman with cognitive impairment and severe language disorder, who presented with her parents to the University of Michigan Reproductive Medicine Clinic in order to be evaluated for donor intrauterine insemination. I'll be using the acronym IUI. At the request of her parents. Much of the information that was provided during these visits was collected from her parents themselves. She has communication challenges, including delayed speech and learning disabilities that have been known since childhood, but it was unclear whether or not she had been previously diagnosed formally or undergone any sort of neuropsychiatric testing. She had never been sexually intimate, is unpartnered, and had never had a pelvic exam previously. In her adult life, and works with a psychologist who has concerns about her ability to understand the process of IUI and provide informed consent to the procedure involved, which also includes carrying a pregnancy for 9 months. The psychologist recommended to us that we go ahead and proceed with neuropsych testing for a full evaluation of N's cognition and communication disabilities. So we went ahead with neuropsych testing, and it demonstrated that N had severe language impairment and what was labeled as borderline intellectual ability. The patient had a visual learning style and benefits from communication that doesn't rely on language. However, as the complexity of visual information presented increased or required flexible or higher order reasoning, and struggled with the ability to understand and express the consequences of the information presented, particularly around IUI and pregnancy. So the reproductive, endocrinology, and infertility team ended up consulting the Office of General Counsel, so our legal team here, and informed the patient's parents that based on her neuropsych testing, her parents would need to seek legal guardianship in order to provide any sort of informed consent for procedures happening in that clinic and throughout our hospital system. Her parents subsequently obtained guardianship and wanted to proceed with IUI. At that point, the ethics team was consulted. So there are two main ethical concerns that our team was really thinking about as we approached this case. The first was thinking about assent for a procedure and the process of carrying a pregnancy from this patient and whether or not that was possible. And also the patient's ability to parent given her cognitive disability. So we really want to be sensitive to generally a patient population who had been historically marginalized and even harmed by the medical system, particularly in obstetric care, while also balancing that with protecting bodily integrity. There is no medical contraindication to proceeding with such care. And additionally, professional guidelines support the ability to say no to providing this care, but don't actually clearly define under which conditions we should be saying no. So zooming way out, I think it's really important to frame this case in the historical context of healthcare for disabled people in the US and different historical events that led to the formation of the disability and reproductive justice movements. So first and foremost, we can't talk about the history of obstetrics and disability in the medical system without acknowledging the eugenics movement and also the broader history of racism and obstetric violence in this country. Black women who were enslaved were denied the rights of motherhood, they were denied reproductive rights and the rights to self-determination. Many discoveries in the field of OBGYN that we still use in practice today were made at the expense of harms and gross violations of the Black body. Next, I'm going to talk about two historical events that happened around the same time and are tied together. So first, I'm going to talk about Charles Davenport, who was a scientist who operated out of the Cold Spring Harbor Laboratory. He began a series of investigations into aspects of what he believed were inheritance of human personality and traits. So he looked at things like the genetics of alcoholism, criminality, feeble-mindedness, bad temper, intelligence, and manic depression. He used Mendelian genetics, which is a very simple model of like one gene, one phenotype, or one of these traits as a model for genetic inheritance to support racist and classist ideals. What we now understand about these sorts of traits is that oftentimes there isn't a genetic component, or it's a very complicated interaction between environment, epigenetics, and genetics. Much of what he was studying actually influenced immigration policy at this time. Meanwhile, in the South in 1924, the Commonwealth of Virginia had adopted a statute authorizing the compulsory sterilization of the intellectually disabled for the purpose of eugenics. So Dr. Albert Sidney Pretty was a superintendent of the Virginia State Colony for Epileptics and the Feeble-Minded, where 18-year-old Carrie Buck was one of his patients. Carrie Buck had an intellectual disability and actually had other family members with intellectual disability. And in 1924, she gave birth to a daughter. She was deemed mentally incompetent to raise her daughter, and her daughter was subsequently taken out of her care. Countless people in her community, including healthcare providers, ended up testifying against Buck in court. John Hendren Bell, who was Pretty's successor as the superintendent of the Virginia State Colony, ended up testifying against her all the way up to the level of the Supreme Court. And the Supreme Court ruling found that the Virginia Sterilization Act of 1924 did not violate the US Constitution. And this case ended up being instrumental in legitimizing the sterilization of people with disability. It was only repealed in 1974. So this is one of the most famous quotes from the opinion of Justice Oliver Wendell Holmes on the case. So he wrote that it's better for all the world if, instead of waiting to execute degenerate offspring for crime or to let them starve for their imbecility, society can prevent those who are manifestly unfit from continuing their kind. 3 generations of imbeciles are enough. So the next key historical event I'm going to talk about is the Griswold versus Connecticut Supreme Court case. So before this case, there was a Connecticut law that prohibited the use of, quote, any drug, medicinal article, or instrument for the purpose of preventing conception. Estelle Griswold was the executive director of the Planned Parenthood League of Connecticut, and after years of providing funds to Connecticut women to travel to nearby states for birth control, Griswold and colleagues opened a birth control center in New Haven, Connecticut, in direct conflict with the law. Ultimately, this case, again, was taken up all the way to the level of the Supreme Court, and the court held that the statute preventing birth control was unconstitutional, and that married couples had the right to use contraception without government oversight or restriction. The Connecticut law, in effect, worked to quote, to deny disadvantaged citizens access to medical assistance and up-to-date information in respect to proper methods of birth control. This right to marital privacy was later expanded to a right to privacy with regard to intimate practices, regardless of marital status. Next, I'm going to talk about the Title X Family Planning Program. So the Title X Family Planning Program was put in place by President Nixon, and this program was born out of federal subsidies to help low-income families with birth control. It came about in 1965 as part of President Lyndon Johnson's War on Poverty program, and this program specifically aimed at providing comprehensive family planning and preventative health services for low-income, underinsured, or uninsured individuals. It worked by granting funds to individual community-based clinics, and of note, despite claims by President Donald Trump, these funds cannot and have never been allowed to be used for abortion care. The last historical event I'm going to talk about is the formation of the Committee to End Sterilization Abuse. So this was founded by Dr. Helen Rodriguez Trias Dr. Raymond Rako and Maritza Rastia in response to sterilization efforts in the US that disproportionately affected Latinx, Native, and Black women. This was born specifically out of Dr. Rodriguez-Trias's work with her own communities in New York City and Puerto Rico, and it led to the creation of the Advisory Committee on Sterilization. This committee was a coalition of groups that developed regulations to help protect women using the public hospital system in New York City. So this brings us to talking about reproductive justice. So some more historical context that colors the decision-making around our case is the development of this movement. So in June 1994, 12 Black women created the reproductive justice movement after being denied the same protections and care as their white peers. This movement works to center intersectional identity and examines how multiple systems of oppression work to hinder just care for marginalized groups. So for some context, Black women have the highest rates of poverty, 20% are uninsured, and Black patients die 4 times as often because of pregnancy-related causes. This movement reflects and continues to reflect the lives and experiences of Black women and Black people in the US who have been denied protections and equitable care in the face of these injustices. And this movement posits that women have the right to have children or not. And these children have the right to be parented in safe and healthy environments. Reproductive justice emphasizes the need to listen to diverse voices, to incorporate human rights and an awareness of the intersectionality of women's identities into a conversation about reproductive care. And it's really grown to amplify the voices of queer people, people living in poverty, and those living with disability, just to name a few. It works to collaborate with other social justice movements. So thinking about disability ethics and the disability justice movement, I really just skimmed the surface with the historical events that I chose to talk about today, but the United States has a long and controversial history of discrimination against people with disabilities, often at the hands of the medical system. Disability ethics looks to protect vulnerable individuals from historic injustices through thinking about issues like autonomy, informed consent, and protections in the research setting. However, this has to be balanced with the principle of preventing harm. On the one hand, there are legal procedures now in place to protect vulnerable individuals from historical injustices, such as involuntary sterilization. But on the other hand, individuals with disabilities often face discrimination and inequitable access to medical care and research participation even today. So our healthcare system is not designed to be navigable by differently abled people. This is because of limitations in the physical healthcare space, lack of accessible resources, describing medical procedures and general health information for the public, or who is represented amongst our medical trainees. Disability scholars note that disability is often a reflection of the built environment. So making spaces physically accessible and conveying information through written pamphlets, braille, pictures, and with the use of translators can kind of begin to break down these barriers. My call to action for all of you on this call who are healthcare providers is to get more people with disability in the medical education space. This will allow multiple perspectives to help shape our curricula and identify where biases, ableism, and other things that are anti-disability are baked into what we learn. So back to our case. Ethics met with the patient, her mother, and the OBGYN team to discuss patient and family desires and understanding of the procedure itself. The patient's parents emphasized to our team that they really wanted grandchildren in order to continue their family line, and that's why they were going ahead with IUI. We ended up discussing the risks of the procedure itself, risks associated with carrying a pregnancy for 9 months, and tried to better gain insight into the patient's understanding of what this all entailed. Ultimately, the patient was not able to communicate understanding of these risks back to us. In this case, we ultimately deemed it impermissible to proceed with fertility treatments, as doing so was a violation of the patient's bodily integrity. So here, going back to the ethical concerns that we were thinking about, conversations around the patient's ability to parent weren't even relevant in our decision at the end of the day. It was really about this piece of being able to assent for a procedure and the process of being pregnant. So for people with disabilities, the current discourse addresses improving access to things like ART and takes into account considerations for supporting parenting for those who might need help. but it can often leave ill-defined how to proceed in situations where ART risks being a violation of bodily integrity. Reproductive justice supports the right to parent or not. Here, it was actually the process of becoming a parent that was an ethical violation, and the conversations around the ability to parent were not part of our calculus. Healthcare professionals have to guide decisions about ART for people with disabilities by balancing their right to conceive and parent children while also not indiscriminately performing medical procedures that could cause serious harm to someone who cannot provide consent or even assent for such care. Bodily integrity is sacrosanct. When patients can't make decisions for themselves about their bodily integrity, we must take every precaution to avoid violating the body and causing harm. So in this particular case, we couldn't be sure what the patient wanted or understood. And because of this, we couldn't ensure assent. And so we can never be sure we were adequately preventing bodily harm or protecting the patient from obstetric violence. The biggest takeaway that I'd like to leave you all with is that this fraught history that I, again, only began to skim the surface of really shaped a lot of our thinking and left us thinking about reproductive justice and disability ethics in this case. And it's something that shouldn't and can't be overlooked in future cases like this. Thank you all so much.
Thank you, Anna. All right, we're gonna switch over to Leah, and then please, if you have questions, you can put them in the chat or in the question and answer while folks are speaking, and I will turn it over to Leah.
All right, sorry, just lining this up. Is everyone seeing my screen okay?
Yes.
Okay, great. So I'll get started. So my presentation today is called When Prima Facie Duties Collide, Navigating Patient Refusal of Basic Nursing Care. And I have no disclosures to share at all. So we'll start by talking today about the characteristics of consults that we've been receiving for refusal of basic nursing cares. And then we'll talk about our ethical analysis of key principles that we have to consider when we're dealing with refusals, as well as how do we make practice recommendations and implications for policy changes. So, over the past year, we received many consults for patients refusing basic nursing care. You see, based on this graph, there's kind of a steady increase from one consult in 2015 all the way to 8 in 2025. It's interesting because for these consults and these patients, they were not refusing care intermittently, but were kind of consistently refusing care to the point where they would be potentially covered in excrement or developing sores from lack of turning or having festering wounds due to refusal of nursing care. And I think it's really helpful to define what we consider basic nursing care throughout this talk. So that would be any kind of low risk intervention with a high reward. They're cares that a reasonable person would want to do for themselves to maintain or improve current or future health outcomes. We can think of like just cares that you would do at home, taking care of yourself, or even like in a hospice facility. And so it's interesting because our institution currently does not have a policy for how to navigate these situations. So in early January, our ethics team decided to reach out to nursing leadership due to the increasing number of consults. And our team was really trying to set out to create a unified process for how to navigate these patients. So nursing leadership asked us these questions. How many consults? Do patients have capacity? Who is submitting these consults? And which unit or department are consults coming from? And so for our methods, we essentially searched through our database of consults. We used key terms like hygiene, wound care, nursing care, bathing, toileting, turning, and essentially collected information about the patients as well as information about the consults itself, which we'll see right here. So we did have about 35 consults for 31 distinct patients. All of our patients were notably adults with an average age of about 50, ranging from 18 to 92. It was really interesting because about half of our patients were deceased at the time of our review, with a median patients passing at about 48 and a half days after we were consulted. If you look at the granular detail, about 4 died within 30 days, 3 within 31 to 60 days, 2 patients from 61 to 100 days, and then 5 patients over 100 days. We also checked out the LACE score. So a LACE score is essentially a score that's used to indicate the probability of a patient being readmitted or passing. And the range is normally 1 to 19, where a score of 10 or higher indicates like a very high likelihood that a patient would pass away or be readmitted. And so ours was 12.8. So that kind of just indicates how sick these patients are that we were being consulted on. Um, then we looked at the patient characteristics, and we did notably kind of split the consults to see, where is this refusal of care is the primary reason, either one of the primary reasons, if not the only reason for consultation, versus cases where they just discussed the refusal of cares, but they weren't really ethically concerned about it. So we had about 25 or 71% of those cases. We also wanted to see whether patients had capacity or not. So about 37% did have capacity, 60% did not. There is one patient where capacity was kind of unclear. We also looked at legal guardianship. 23% did have a legal guardian, while 6% were kind of pending that. And then we also discussed the use of restraints. So restraints were only discussed in cases where patients lacked capacity. And of these 26 or 9 cases where they were discussed, only 2 patients ended up experiencing restraints in any way. So the team certainly tried to avoid them. We also kind of wanted to notice, like, what is the medical history of these patients? They're very ill, which was supported, like, objectively, by the short duration between the time of consult and death, as well as a high LACE score. So you see that, like, we had many patients, 5, who were at end of life. Patients also could fall into the category of chronic neurological disability. We had 7 of those. And then other patients had psychiatric illness. Um, and I think these categories are interesting to think about because, especially for someone who's end of life, it might feel very morally distressing or difficult to compel an end of life patient to participate in basic cares that they don't want. Similarly, chronic patients with chronic neurological disability might have severe pain or be very uncomfortable with their care at the time, or may have very little agency over what happens to their person. So that can be uncomfortable. And we'll talk more about the psychiatric illness as well. We also wanted to look at why patients were refusing care. And in most of our notes, there wasn't a reason. That doesn't mean that the patient didn't explicitly state the reason, but we just didn't have it, filed away. But for those who did have a reason, most of them were stating uncontrolled pain, while others talked about shame, anxiety, or lack of familiarity with staff. We also looked at what types of care was being refused. So hygiene, 54% of the time, wound care, 43%, turns, 26%, and then other cares, 23% of the time. We also looked at where these consults are coming from, whether it's like the service or the unit. And if you look at this, you won't really find a trend of cases are coming from a specific service or a specific unit. So it's very heterogeneous. We also looked at who placed the consult, and we noticed that most of our consults are being placed by a primary team, whether it's medical or surgical. Which is interesting because there's only 3 consults that came from nursing staff, and most of the literature on this topic talks about nursing distress. In this space. So I think the fact that 19 of these consults are being placed by the primary team shows that this is a large scale multidisciplinary process where lots of different perspectives are being considered and the team is quite unified. So I just want to quickly summarize kind of all of that data. So when we think about the consults that we got, I think the common thread here is the patients. The patients who are refusing nursing care tend to be either very sick nearing end of life, struggling with chronic neurological disability, or having really uncontrolled psychiatric illness. Um, and so patients might feel like a lack of control over what's happening to them and find refusal of cares either as a way to exert control over what's happening to them, or maybe they just have really difficult symptoms to manage and they haven't been like medically optimized. So, part two, is it ethically permissible to provide cares over patients' dissent or objection? I think this is our ultimate question and what we'll be considering throughout our analysis. So, to answer this question, we have to consider what it means to uphold somebody's bodily autonomy. Um, which is essentially letting someone make decisions about what happens to their body versus dignitary harms that can occur when patients are left in really dehumanizing, unsanitary conditions. So, first, we'll think about autonomy, and we just want to remember that our respect for our autonomy comes from people's unconditional worth. And so it is a well-established legal and ethical principle that patients do have the right to refuse medical interventions, even if there are severe consequences for doing so. And this is because we see respecting someone's refusal as a way to honor their autonomy. I think what's really interesting in these cases is that patients aren't refusing medical care, they're refusing basic nursing care. And this gets really tricky because there isn't legal or ethical precedent for whether autonomy extends to refusal of nursing care. So I think that's why these cases are so interesting. But I do want to kind of remind us all that autonomy can sometimes be overridden by competing moral considerations, which we'll kind of discuss on this side. So, exactly, what are those considerations to override autonomy? Primarily non-maleficence and beneficence. So, negligence falls under the category of non-maleficence, and it's basically a legal and ethical standard where you're failing to exercise a standard of care, and by not providing that care, you are causing direct injury to a patient who may suffer measurable harm. And I think when we think about the cases we're discussing, by declining basic nursing cares, patients are facing both dignitary harms from being left in unsanitary conditions, as well as physical harms like infection or development or progression of wounds. Um, and I think as professionals and as a medical institution, it's important to remember that we have moral and legal standards to provide these cares by like Adult Protective Services and then CMS. So and I think the adult protective services piece is particularly interesting because even if patients are not in the hospital setting and might be in their own home, adult protective services does mandate a certain level of hygiene, and will kind of intervene if that's not being met. But we also consider beneficence. So, the principle of beneficence can give us grounds for restricting autonomous choices. So, there are established principles of paternalism where it is permissible to limit autonomy in order to prevent harm and promote a patient's well-being. So, we consider this soft paternalism if a patient doesn't have capacity. And this is really important because if a patient doesn't have capacity, they can't really express autonomy. So if they're making a decision that's harming them, you can't honor their autonomy by respecting that choice. That's not respecting their autonomy, even if it feels like it might be. Whereas on the other hand, hard paternalism occurs when we override a capacitated patient's informed voluntary choice to prevent harm. And I'll kind of discuss the criteria for that later. Um, and so I think we want to return to our question, is it ethically permissible to provide cares over a patient's dissent or objection? And, based on our analysis, because of the dignitary harm, negligence, and beneficence, we can say that those three things kind of outweigh the bodily autonomy argument in this context. And I think this kind of goes to show that there are limits to autonomy in a hospital space. And the whole point of being in a hospital space is to provide cares for the direct benefit of a patient. I also think it's helpful to think about this through like a pragmatic ethical lens, to think about, what does it mean to us as healthcare providers, and as an institution as a whole, if we fail to provide basic nursing cares, what are like the legal and ethical ramifications of that? And I think it just goes to show that we do have an obligation to provide a minimum level of care, even if that means kind of going over somebody's autonomous decisions. And so, what's the best way to approach these conditions? We essentially developed recommendations that start with persuasion, and that's very consistent with existing approaches in the literature. Some scholars have raised concerns that persuasion can become coercion, but I do think it's important to remember that we shouldn't shy away from persuasion because we do have an obligation to persuade other people when their perceptions could cause them significant harm. And so, how do you try to persuade patients? You start with conversations. You want to understand, why is a patient refusing care? What concerns might they have? I think it's a big opportunity to clarify information and educate patients. So you would try to address missing or incorrect information and explain, like, what are the risks of refusing care, because a patient might not really understand that. Um, Moving forward to contextual considerations that are very specific to that patient, you'd want to think about what barriers are preventing that patient from accepting cares, and what are ways that we can optimize conditions to help with those barriers. So a lot of times it's involving specific specialists. Sometimes it's palliative care, sometimes it's psychiatric nursing liaisons, as well as specific interventions for barriers. So, you know, conceptually, we think of how can we provide the minimum frequency and duration of care so that we're not, making patients more uncomfortable than they have to be in these situations when they are refusing cares. And then for specific barriers, I already talked about what team members we might get involved, but for pain, you might pre-medicate the patient. For anxiety or depression, you can involve psychiatry. You can try to optimize their medications. For staffing, you can try to use staff that patients are a lot more familiar or comfortable with, or limit the number of staff in case that's a concern. Um, and so the existing literature really stops at the persuasion piece. They don't really offer a way forward when patients continue to refuse despite persuasion. And it was very interesting because only papers that were focused on what real nurses do did recommend like directly providing cares over patient dissent or objection. So whether a patient will have capacity or not, we'll always consider the safety of the patient and the healthcare team and try to encourage patients to engage. A lot of times we can explain what is going to happen and offer the patient real choices about, when might this turn happen, under what circumstances, with what team members, if possible. But we really want to avoid false choices like saying, do you want to be turned, if we know we're going to turn them anyway. Um, and with soft paternalism, I think there's more of an impetus to provide cares over dissent because a patient isn't making an autonomous choice. Sometimes we'll need medications for agitation. We think of this as like symptom management to optimize conditions, kind of like we were talking about here. We definitely want to avoid restraints as much as possible. And we kind of understand that it's not ethically permissible to use restraints in a chronic way. So the only time you could do this would be very rare occasions where a patient is, continues to physically object to these cares. And we're just trying to get them back to a baseline in a very like acute short-term setting. And then I want to talk about hard paternalism too. So there are criteria for going over capacitated patient's decisions. So that patient would have to be at risk of significant preventable harm, where the action would prevent the harm and the benefits of this action outweigh the risks. We also think about like, are there alternatives to going over their autonomy? And in this case, there wouldn't be reasonable alternatives, and we would always use the option that will restrict their autonomy the least. And so we had some cases where there were behavioral contracts made, explaining the consequences of what might happen if you don't agree to care. But for many people, it was just saying, hey, I know this is, not ideal, but this is how care is going to happen. How can we engage you and help you make as many decisions as possible? Um, and I wanted to show some real data about how these recommendations were kind of implemented. Um, so you'll see that about 12 of our cases were resolved with persuasion, and I thought it was really interesting that half these patients were capacitated, whereas the other half were not. Um, Soft paternalism was used pretty frequently with 9 patients, and hard paternalism was only used 3 times. But if you look at the data itself, this was only in 2 different patients, one of whom required 2 consults. And then we did have one case where we permitted objection due to like a history of trauma. And this was only 1 patient. They just happened to have 2 notes. Um, so I think, in conclusion, well, first, thank you very much for your time. I really appreciate you guys hearing me talk about this topic. It is a really difficult topic, but relatively uncommon. Although we did have 35 consults over 10 years, I think that this probably comes up very, very frequently in the clinical space where people are refusing cares. And I'd say our nursing team and our other teams can be very good at the persuasive piece, and that probably resolves many of the situations before they become ethics consults. And so we're going to continue to work with our nursing leadership to kind of implement these policies and adjust them as needed. Um, I have some quick acknowledgements. Just wanted to thank everyone in the department for their help, specifically Evelina and Jay. They helped with the project, and so did Janice. Um, I also wanted to thank Janice, Rachel, Dr. Schumann, Dr. Verkler, Amy, and all the staff who I've had the opportunity to work with over the past year. It's been a really, really great experience. I really appreciate it. Thank you so much.
Thank you so much, Leah. And I'm going to invite you back on camera. Give folks a minute. We've got a couple of questions in the Q&A. So I will start there. For Anna, with your case, what are some thoughts? I think you've reflected a lot on how do we help patients, especially those with neurodevelopmental disabilities, engage in this space and have access. Are there things that you've thought about for helping with informed consent and making sure that patients have sufficient understanding, especially for procedures like ART?
Yeah, I mean, when we think about capacity decisions in general, in this space, like we often refer to Applebaum's criteria. So these criteria of like what allows someone to make a capacity decision. And we talk about how these criteria apply to specific decisions only. So like you can say that someone needs a guardian and generally will not be able to make capacity decisions more broadly, but I think it's important to like think about how we can involve patients at every step at different decisions. So just to quickly review, Applebaum's criteria is the ability to communicate a choice, understand relevant information that is presented and reflect that back, and then appreciate like risks, and be able to say like I understand those risks and that those risks apply to me. So here it was really hard because I don't really think this patient could do any of those things, and so I think as much as we can, like engaging, using the tools that we know work for this patient, like visual communication as best we can, and trying to have that communicate back to us. But here it just wasn't possible.
I think the neuropsych testing in this situation was really key to try to understand are there ways we could optimize communication and understanding and expression. Ultimately, the neuropsych testing said that even if we could, like, there would be no way to know for her to be able to communicate back nuanced understanding of things. And so we just felt like without that assurance, given the bodily integrity pieces, that proceeding would not be possible. But I do think it's like potentially right, like it's a lack on our side, right, that we don't have the right tools to communicate with her and for her to express things. So that limitation of the setting and our current understanding of things could really impact the access piece there. And then there isn't really a formal definition for assent per se. We kind of looked at the one that is used for pediatrics when research studies require assent from pediatrics, and sort of extrapolated from that to the application here to think about what would assent look like in this situation. Leah, for your presentation, how do you address the balance between persuasion, recommendations, and coercion? Thinking that, yes, of course, we want to try to optimize the conditions and remove barriers and things like that. But the fact that there isn't a lot of literature here, can you expand on any of the cases where we permitted the objection, specifically if that was based on the severity of trauma, or how do we arrive at when we would not override autonomy?
Yeah, I think the coercion piece is really interesting, because like if you think about the behavioral contracts, like in a way, some might consider that to be like coercion if we're saying like you do this or there are consequences such that like you won't be able to be at the hospital. But I think you can frame it as coercion or you can frame it as hard paternalism, and one might feel better than the other. And I think like looking at the hard paternalism criteria, we saw that in many of those situations it did fit that criteria. But I think also important to know that that only happened 3 times for 2 patients. So it is something that's like exceedingly rare, and we definitely try to avoid it. I think for the patient who we permitted the objection, that was a really interesting case of a patient with like borderline personality disorder, and it was very unclear like her capacity situation, but the disease was so progressed that that patient actually had a high output intestinal fistula just due to self-injurious behaviors. So I think it goes to show that like it was very uncontrolled. And I think sometimes when we think about things from a pragmatic ethics lens, it's like, what does that actually mean to like compel cares for this patient? And patients with BPD do tend to have like very histories of very extensive trauma. So it's kind of balancing not wanting to do that, but also like it's not ethically permissible to chronically use restraints and do all these things to provide cares for this patient. And I think this is the type of patient where it wouldn't be just trying to get the patient to back to baseline to use restraints. This would be like every single time we're trying to give cares, we have to, you know, force that maybe with like strong medications or even physical restraints. And so I think that that was probably the primary driver of why that didn't happen. And also some of these patients would be like leaving the hospital to go to more outpatient care settings too. So I think a lot of times we wouldn't necessarily compel treatment on patients who are going to be discharged shortly anyway.
Thanks, Leah. All right, so I'm looking through, trying to make sure I can collate any of these. There's a question about in the first case, how much are we worried about sort of doctor shopping? Is one piece there, and then the other piece of a question of like, how much does what the parents want weigh into, like, should it even matter what the reason is for coming forward for treatment?
Yeah, so to answer the first question, that is very much something we worry about and still talk about. I think we were limited to what we could do within our own institution. So actually bringing on Office of General Counsel and ethics allowed, like rather than this one doctor in this one clinic saying like I don't feel comfortable doing this procedure, and so then I have to refer to a colleague who then maybe also has to say no. It kind of gave us some like grounds to stand on that like as an institution it's ethically okay to say no to this, and so we're not going to provide this care in that clinic. unfortunately, like I would say the realities are that we can't prevent this from happening in a different institution. Some like electronic medical records can be read between institutions, so like hopefully they can like see what we thought about this, but can't control what other doctors do, and that is like an unfortunate reality that we've grappled with a lot, I would say, about this case. So it's a great question and something we also thought about. In terms of like ends parents desires, I guess first part of my answer to that question is like the reason I put it in is because most people's first like knee-jerk reaction and question to this case was like, why on earth did they even want this to begin with? And so that's kind of their why. I think in terms of our own ethical analysis, their why, I agree that like it matters what N wants and what this patient is able to convey as her desires. And so I think I could see a case where like her parents came to us and said like she's expressed really wanting to be a parent and we want to help her do that, and our parents are helping facilitate that communication, but they're expressing what this patient's autonomous wishes are here. That wasn't happening, and so we didn't like weigh what her parents were saying they wanted for themselves by and using kind of like her as a means to that end. And so I think that is like a very important distinction to make, and that's, I think, the why here was really important for that reason, is the why something having to do with what the patient themselves wants for and understands will happen to their own body versus is the why about what someone outside of this patient wants for themselves.
Great, thank you. All right. Question. So for Leah, how in your model, thinking about how you would weigh considerations for, the clinical pieces, for example, is it more optimal to ethically use a Foley and go above a patient's assent less frequently? But that might be a less optimal option for hygiene overall.
Yeah, I think this is a really interesting question. I suppose sorry, I just was looking at the question and then more questions come up. I think for like considerations of like, do you use a Foley or do you medicalize someone more because they're objecting to cares, and perhaps by medicalizing them, they'll have like less frequent cares and stuff. I think ultimately that has to be like a clinical decision from the clinical team in terms of like what are the risks and benefits of that care. And I think like ultimately our goal is not to like make someone more medicalized choose refusing cares. So and it would also have to be like, would the patient prefer that? So I think it's like, what's like the risk of infection or the risk of like urethral erosion or like trauma or something, versus like the benefits of that. But it would, I think it would really just be centered on what the patient wants. Like if the patient is really like asking for that or saying, this would be so much better, easier, then we would consider it. And then we would still have to say medically, is this necessary? Because I think if it's still like a non-beneficial treatment, that wouldn't actually help them, like in a risk benefit analysis, then we probably still wouldn't do it.
Okay. Anna, going back to you, is where is the line drawn for a patient who can communicate and make decisions but has intellectual disability and emotional challenges in deciding to carry a pregnancy?
Yeah, I mean, I think like kind of what I spoke to this, we have this like really fraught history that has, I think, fortunately led us to a place where like we try to get to yes with patients. So if a patient is like clearly communicating to us in like a capacitated rational decision that like they want to carry a pregnancy and they have intellectual disability, or there's some like emotional challenge in deciding to carry a pregnancy, we, I think, would use the tools that we have to help them like be able to do that. So whether that's like involving perinatal psychiatry to help with like the emotional pieces of this, helping like with parenting courses, helping to figure out like identifying supports for this patient, like we do really try to get to yes, which is why I think this case felt so uncomfortable to us, because we really did have to say no, but that's not like usually the framework under which we're operating.
Thanks. And then for the autonomy gray areas, thinking about, can you think of situations where refusal of care might straddle both like clinical and nursing, and how you would sort of navigate, the basic care versus more medical care if they come together?
Yeah,
Medicare.
I think like the wound care piece is actually a little bit more gray, because it is somewhat of like a medical intervention, especially depending on like what you're using. I think a lot of people at home wouldn't necessarily consider like wound care to be like an ADL or something. And I think that's like how I kind of conceptualize the basic nursing cares is like what are things that like every person just has to do. Um, and I think it does make it certainly like more challenging. And I think because it's a little bit more gray, you would probably need, in order to go to a soft or hard paternalism standpoint, I think it's easier to go to a soft paternalism standpoint because I think if the patient doesn't have capacity and is refusing it, it's like these are wounds that need to be treated. They have serious like risks of infection and things that can cause ultimately like lead to death, depending on if you get like osteomyelitis or sepsis or this or that. So I think even for wound care, it's pretty easy to compel that in a non-capacitated patient. But I think for a patient that does have capacity, that gets a lot stickier. And so I think it's like how severe are the wounds and like um how much of like an environmental challenge are they, I guess, because when I think about the basic cares we mostly focused about, part of it was about like how do we keep this space clean and safe, not just for the patient, but for the staff who are working there and just for like infection risk in the hospital as a whole. Um, I'm sorry, that's not really like a clear answer, but
All right. Well, thank you, everybody. I'm just cognizant of time. So we're going to thank our panelists. Thank you so much, Leah and Anna. And it's been great working with you. And they're both graduating from the fellowship. This is their last, star on top of the uh, so thank you. All right. So just as a quick reminder, Amy had put CME and CEU information into the chat. So please grab those if you haven't had a chance. And we will see you next month. All right. Take care, everybody. Bye.